Every everybody's on, but we'll hit record anyway. Okay, so last of our fellow talks. Jack, take it away, man.
Great. Awesome. Well, most of you know me, but my name's Jack, one of the last ones of of the presentation for one of the fellows here. I chose the topic to talk about sports cardiology, given its relevance current, with many things that you do, especially with pre-participation physicals, and it's really relevant for our boards. And also throughout this talk, I also thought it would be nice to kind of do a year-end review, starting with this first image that we see here, with Killian in that awesome orange jacket there. Things that we're going to be talking about here today, objectives, is talking about normal EKG changes in athletes, having EKG abnormalities, cardiac and causes of sudden cardiac death in athletes, hypertension, and throughout the lecture, kind of talking of having a little check-ins of review questions. And here, this is kind of the overall outline, and this is a really, really great diagram from Dr. Dresner, the sports EKG article that we should all now be very familiar with. However, for me, this was kind of difficult to really just essentially memorize all these categories. I wanted to put some good context to it. And hopefully this will make it easier for you also as well to understand the things that are normal, the things that are abnormal that we should get further testing. Looking at just review of a normal schematic diagram of a normal sinus rhythm, except for that Q wave, but you have all the different components and the parts of the cardiac cycle, and then having all those intervals. And we're going to talk a little bit more about each different segments along with certain pathologies. So starting off with kind of just talking about normal EKG changes in athletes, this part to really understand the EKG changes, I kind of like to set two different kind of ground rules here is that because of the conditioning and exercising, the heart will have various different adaptations. And first part is having an increased vagal tone, which then causes a decrease in resting heart rate. And then the second part of this is that because of, like all other muscles, the left ventricle will enlarge and thicken and increase in mass, which does increase in the stroke volume. And a couple of things to have in your mind about numbers, and they do test this. What I've seen in their CAQ practice exams is kind of talking about left ventricular wall thickness. Know that normal is less than 12, and then pathologic is greater than 16. They also want it to be kind of differentiated from hypertrophic cardiomyopathy, which I'll talk about a little later, and all the numbers that are associated with it, which we'll touch a little bit more about. So the first part about increasing parasympathetic tone is kind of with that decrease in heart rate. Can you guys see my cursor here?
Yeah.
Yes, I can
Cool.
see it.
Awesome. So as you guys know how to count boxes, I have a schematic here, but basically it's 300 divided by how many boxes. This one is 7, so you can know that this heart rate is 43. So that happens with kind of changes in AKG changes and kind of having that slower heart rate. Another thing that you would also see is early repolarization due to our athletes, and you'll see this right here in that smooth um, elevation and ST elevation there. Other part of it here is kind of the sinus arrhythmia, having um, kind of variations in your sinus rhythm due to respiration, and this all resolves when you start exercise. Also, along with the parasympathetic tone, is junctional rhythm and ectopic atrial rhythm. So talking about that, it really boils down to basically the P wave. It just gets slower due to adaptation and changes. So because of that, your Q wave just is faster. So then your P wave might get kind of buried in the QRS complex, and that's your junctional rhythm. In terms of ectopic atrial rhythm, you kind of think about the P wave due to kind of conditioning will have kind of different morphology, as you can see on the right side there, with having that negative deflection of that P wave. And all this is normal, like I said, and that the sinus rhythm all return when you start exercise. Last part of the parasympathetic tone is kind of talking about the AV blocks, which you guys probably are very familiar with now at this point. But because of the conduction with the athletic changes, so the PR interval becomes longer. So it's greater than 5 small boxes. And then the second degree AV block, as you can see there, I call it longer, 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 and then drop, as you can see there, where if you look at the first set here before each after these drop, you'll see that PR interval is a little shorter here. It gets longer, and then it drops. Also known as Winky box. So yeah. And then looking at the other part of the adaptation is your cardiac mass increases. So therefore, the things that you can see on EKG is having that QRS voltage be higher. And you can see that. I know there's a formula for it, but really it's pretty much you can see the V and V1 where this the S wave is much longer, and then you can see a V5 and V6 where the R wave is longer there. Other things that you might also see is incomplete right bundle branch block. Incomplete versus complete has to do with the QRS interval. If it's less than 120, it's incomplete. If it's more than 120, it's complete. And here's just a schematic to kind of get you familiar about right bundle branch block. As you can see there, having the morphology in V1 and V6, with V1 being M and then V6 being W. I find that right bundle branch blocks is a little easier to identify than left bundle branch block, which I'll kind of talk about a little later. Other things to also note outside of kind of the cardiac adaptation is just from their research, they also found that there's certain normals among different populations. And in this one, they always love to talk about kind of the changes you see in plaque athletes. And they see here that you'll have T wave inversions in V1, 2, 3, and 4. And then the other thing that they also love to test on is that this adolescents athletes, especially with the age less than 16, you will see T wave emergence V1 to V3. All right, and we're off in terms of our our fellowship journey here. So this is our first events at the Pan Am Games, the Master Games, and on the left we were covering badminton, volleyball, judo, and then on the right that was our first triathlon. Awesome. So I'd like to kind of do a little quick review here with you guys. So this is the question. You are seeing a 15-year-old male athlete in your clinic for pre-participation evaluation prior to his high school basketball season. They went and did a community screening and they brought in an EKG for you to review. So this is the EKG. I'll give you like 10 seconds just to review it real quick.
Too many PVCs.
Awesome. But I'll give you the question too. Which of the following EKG findings should prompt additional evaluation?
Sorry, I jumped the gun.
No, that's great. The I didn't talk about the PVCs there, but knowing that you have two PVCs is a warrant evaluation. But the point is in this, that having that left ventricular hypertrophy, having the second degree Mobitz type 1 and resting heart rate of 42 and T wave inversions are all normal changes because this kid is 15, so the V1, V2 T wave inversions does not matter as much. Obviously, it has to correlate with their symptoms and family history. All right. And we are off to Colorado here at the Fellows Conference. There's 4 of us here. Here's probably my and Kevin's first time doing MSK ultrasound. And then here's Kevin Killian here giving his presentation before winning our group and going up and doing the formal presentation about face protection in hockey relating to rates of concussion. He brought home second place there, which is awesome. Any questions about EKG changes with normal and athletes? Cool. Alrighty. Next part up, kind of want to talk to a little bit about EKG abnormalities. This slide kind of gives you kind of what are things to look at. I mean, there were a lot of like abnormal findings on EKG of that list, over 10 things. Kind of boil it down to basically four. And if you kind of do these four, the other ones are just more or less recognized. So first one would be kind of knowing that your T-wave inversions and knowing that it's in the lateral and inferior lateral leads. So inferior would be 2, 3, and AVF, and then lateral will be 1 AVL and V5, E6, but really it's pretty much V5, E6 for the lateral leads. The ST segment depressions, which we will kind of talk a little bit more about, kind of looking at here. And then you have pathologic Q waves, which is here, which we will talk a little bit more about, and then ventricular pre-sextation, which we will talk a little bit more about. But this is kind of just the kind of the key slide to kind of remember that those are the four things you should look for to basically just tell you, hey, this is abnormal. So in talking about kind of the very different causes of sudden cardiac death, the first kind of topic is kind of the congenital and structural cardiac diseases. You can see how there's many different etiologies, but I'll go ahead and kind of stress a little bit more based on the CAQ practice exam of these four. So first one that we have to know really is the hypertrophic cardiomyopathy, or HOCM. And this is because it's the most common structural cause in young competitive US athletes. And like I mentioned, the numbers, for whatever reason, these were answers of some test questions. So we're knowing that the wall thickness is greater than 16. So it has to do with that, as you can see the picture here, that thickened ventricular septum. And that because of that thickening, that septum to free wall is greater than 1.3. And then because of that, then you're pushing into the left ventricle. So your left ventricle is smaller than 45 millimeters. Just somehow remember in the back of the brain, some of these numbers, they sometimes might test that. I've also noticed the pattern, like, in terms of symptoms, unfortunately, all of them really have more or less the same of like chest pain, dizziness, syncope, dyspnea, palpitations. These aren't, unfortunately, really that helpful when you're looking through the stems of the questions. But the major thing that they will test on here would be relating to hypertrophic cardiomyopathy, is about the increase or decrease in the murmurs. So the way that I remember this is has to be a key based on the venous return. So knowing that when you do a Valsalva or going from squatting to standing, you are decreasing the venous return. Therefore, your interventricular septum is kind of blocking a little bit more. So that will cause your murmurs to increase. And then conversely, when you're going from lying down to squatting, you are really increasing the amount of blood flow going back. So therefore, you're kind of opening that up and less blockage from that interceptor septum. So then you're decreasing that murmur. Things that you can see: Q waves, T wave inversions, ST depression, left axis deviation, and having that increased QRS voltage. Right here, I have highlighted here having that ST depression and having that T wave inversion and that V6 there. I'm not very good at left axis deviation, so I needed a little brushing up and review here, but this slide is for you kind of to take a look at if you need it. I doubt that we're going to have to figure out axis to that extent, that they're going to give you a one that kind of takes a little bit more to figure out, but here it is if you need it. And the other thing they really love to talk about is kind of return to play. So for Hokum, it's really no participation in competitive athletes in athletics, but maybe there's some thoughts in terms of low static sports. So I put the diagram here about static versus dynamic sports, and then here are the categories and the different sports that fall into the different categories. And this chart's somewhat important, just knowing like roughly which ones are the ones that are more like on the low end and which ones are that are on the high end, and that will most likely help you with getting those answers. The next one up that they really love to talk about is arrhythmogenic right ventricular cardiomyopathy. This one, I felt, I really need to understand kind of that etiology and why this happens. So all the genetic kind of predisposition is all autosomal dominant. So if you just put in autosomal dominance, you probably most likely be right. But some little characteristics here about this disorder would be kind of that it's related to people that are from Italy or Italian descent. And then the thing it has to be most due to is kind of that genetic mutation in the desmosomes. If you guys remember, it kind of is the anchoring protein. And these myocytes, unfortunately, aren't anchored well, so they're slough off, and because of that, they then are replaced by fatty tissue and then scar tissue. And the scar tissue is the reason why the conduction then becomes unfortunately wonky. So like I said, symptoms, they have the usual symptoms that we think about relating to this, and the physical exam aren't really that useful here. But the most characteristic thing that they might test on is something called the epsilon wave in V1 to V3. This wave is highly specific. Now, it is very difficult to pick it up if you're not looking for it. So I doubt they'll just straight up give you an EKG and ask you what this is. But you can see here this little tiny positive deflection blip after your QRS is what you're looking for, and that's called the epsilon wave. Other thing on here will be the left bundle branch block, which again, I'll review a little bit more. It is, I think, a little harder to pick up compared to the right bundle branch block, but I like to think of it as kind of basically V1 and V6 having that notched appearance. And then since it's complete, you'll have that broad QRS, as you can see here on these examples. Because it's all about kind of visualizing that right ventricular wall, echocardiogram might not be as useful. So we might need that cardiac MRI, will be kind of the one that would be used, or possible cardiac biopsy. And these people would unfortunately be disqualified for a competition because intense exercise does increase that progression and causing arrhythmias. Alrighty. And here's back with us in Colorado. We went to the Red Rocks Amphitheater and took a picture there, did some hiking, which was awesome. And then here's us. I think it's maybe later that day. Don't remember the timeline at this point, but we also went to the Colorado Rockies game. This was my ninth MLB stadium, which was awesome to be able to go to. And we had a blast at the Fellows Conference. All right. Question here. During the athletic pre-participation physical evaluation, which of the following findings would be concerning for hypertrophic cardiomyopathy? Any takers on this one?
B.
You say D as in dog?
Yes.
Awesome. All right. Yes, you are correct. And like I mentioned, it has to deal with that venous return. And kind of I talked about if you are having that Valsalva, you have less venous return, resulting in an increase in murmur because of the interventional septum basically blocking the flow and causing that louder murmur there. All right, awesome. Next question here, a 15-year-old male Italian soccer player, they present to you with for the pre-participating physical. Kind of talk about here that family history, an older brother that died from a heart-related issue while training in the military. Physical exams in normal. What would you want to do?
Next up would be EKG.
Great, awesome. So this is your EKG.
Looks like an epsilon wave.
Oh my God, Cody, you're so keen. Uh, so the question here, so what is their diagnosis?
And go B.
Awesome. And this is just, again, I know I'm being silly and belating at this point. This is just an easy way for you guys to be able to detect it kind of in isolation. And then to complete this question, kind of things that you know, if you give them and refer to cardiology, you do echocardiogram, you might see a thin RV free wall. And if you do a cardiac biopsy, you'll see that fibrofatty infiltrate of the right ventricular free wall there. And after we came back from Colorado, it was all about physicals. As you can see me here with both Kevins. Unfortunately, Cody was not in this picture. I believe he was in one of the locker rooms doing physicals at this time.
Yeah, I was thankfully in the bathroom doing physical.
Yeah, sorry, bathroom. Yeah. There were a lot of physicals we did. I want to say each of us at least did 300, something around there. And then here's us at the Tri-City Rock and Roll the triathlon there. Awesome. All right. Next parts of in terms of sudden cardiac death, these ones I'm gonna go over a little quickly. So dilated cardiomyopathy has to do with, as you can see here, kind of having that enlarged left ventricle with that thinning of the wall. The main part here that I really want to kind of talk a little bit more about is kind of that return to play. So if you're asymptomatic and your ejection fraction is greater than 40%, you can continue to exercise. So as you can see, 40% is not normal because normal is 55 to 69, but they're okay with that 40% and asymptomatic. But if you are symptomatic or have family history of sudden cardiac death or have ejection fraction less than 40% or have an MRI finding with the MRI cardiac, then you can only do leisure activity, meaning brisk walking and gentle cycling. And that's important to point out. Another one that they might touch on, again, this is not as popular to test topic, but it's left ventricular non-compaction cardiomyopathy. And for whatever reason, the muscle wall just does not pack down and you get these kind of trabeculations or in deep recesses. And this then messes with kind of the left ventricular's ability to kind of be able to function. And the major thing here is that you need an echocardiogram to visualize or a cardiac MRI to visualize. And this is a little different in that this one needs to have a normal ejection fraction along with that asymptomatic to participate in obviously having no ventricular arrhythmias. And like the other one, if you have symptoms, have abnormal ejection fraction, or having any ventricular arrhythmias, you can only do leisure activities such as walking, brisk walking, or gentle cycling. Next big topic here, a little bit more important, will be the anomalous origin coronary artery. The reason for that is this is the leading cause in middle school athletes of causing sudden cardiac death. And the major one that you want to remember is the left main coronary artery. So basically, for whatever reason, it's just not coming out of the right place where it needs to come out of. As you can see this in diagram, this is the normal one where it's coming out on the appropriate side of the sinus of Valsalva. Here on this right picture that you kind of can see different ways that it can come out of, but basically just know that if the left main coronary artery comes out of the right side or out of the opposite side, that's the kind of the problem there. This one, you kind of want to do echocardiogram. It can be 80 to 90% sensitive. However, it's also based on, the sonographer's experience, the person's body habitus, and your ability to get a quality image. So really the definitive diagnosis is coronary angiogram. So this major big part about this one is more about return to play. So there is right coronary artery coming out of the left side and then left coronary coming out of the right side. So you have two different ones, but know that the right side is not as severe versus the left is much more severe. So if you're asymptomatic and right, you can continue to play. But if you're left, even asymptomatic, you need to be removed from sport. And then symptomatic and then right coronary artery, you do need to remove from sport. They can fix this with a procedure, and then they can consider you kind of return to play after 6 months with correcting that.
Sorry to interrupt, but we had one of these post-op at the VO2 max testing. He had a left anomalous coronary artery
Oh,
that they repaired, and we're testing on the VO2 max to see if he could return to sport.
there you go. Yeah. Yeah, that's awesome. Yeah. I have not seen one personally, although I'm doing exercise testing today. Maybe I'll see something like that. But yeah, one of the more favorite topics to talk about. The other one is our maybe not so favorite, because we've been seeing this since med school probably, but Marfan syndrome that they talk about a lot. Again, autosomal dominant like the rest of everything else, but this one's genetic disorder of fibrillin, the connective tissue protein, causing these constellation of problems through the different systems. And the main thing kind of you want to know is basically this thumb sign that you can see here, where your thumbnail is longer than the width of your palm. And the pectus activatum is kind of just having that area kind of in pouched inward. And then talking about then lens dislocation and ectopic lentis. And then talking about the most important one here, the kind of unfortunate part for Marfan syndrome is having the aortic dissection and rupture, and that's the reason for sudden cardiac death. Unfortunately, typically it's asymptomatic unless you have that aortic rupture, which it spells bad news for the individual. Here is a picture or the table that we have in our book here of all the major and minor criteria. The ones I talked about, those are the ones most likely going to be on your test. These are the other ones. The other ones that they do list on here, they're not as helpful, but they love to kind of test those major criteria that we talked about. So most important thing here is kind of having that echocardiogram to look at the aortic root so you can get that measurement. So if you are greater than 4 centimeters, they would only allow low static sports. And then the other thing is obviously knowing that avoiding contact or collision sports because of that risk of aortic dissection and rupture. Another thing you want to make sure you do is a slit lamp test to look at the lens for consideration of lens dislocation. The bottom picture here is also if that person may also have duroectasia or having that enlarged dura sac, as you can see here with that larger diameter. Great. All right, and here is us off in the fall football season. This was the game where Killian and I had our schools play, our high school's football play. This was the most I think we had in terms of health professionals on the sidelines, which was awesome. The score was a little lopsided, but we all had a great time. All right, questions here. Which of the following is true of congenital coronary artery anomalies?
I think D.
Which one?
D, last one.
Gotcha. Great. Yes, it is D. So first one, they don't really, unfortunately, coronary artery anomalies, you don't really pick it up on EKG. B is true if it says middle school. And then C, they unfortunately don't experience symptoms. So some of them won't even experience symptoms. So awesome. Next question here. 15-year-old come here for pre-participation physical evaluation, positive family history of Marfan's and older sibling. You did review systems negative, physical exam, you find the positive wrist and thumb sign, pes planus, minor pectus perinatum, which is another finding, hypermobility and high arch palate, no skin or cardiopulmonary abnormalities. What statement is correct for further assessment of this child?
D as in dog.
Awesome. You got it correct. Just making sure you want to make sure that you kind of do the slit lamp test, or most likely you're going to send to ophthalmology, and then that echocardiogram to look at the aortic root and measure that to be able to help you guide your return to play and what sports they can do. This is the end of my fall football season, and also this is to give a shout out to my athletic trainers that really helped me throughout the year. Sarah on the left there with Hawken High School, and then on the right, Abby and Christine with Lake Erie football. Alrighty. This I'll kind of briefly touch on all the kind of highlights. Aortic stenosis, we learn a lot about, kind of talking about kind of that stenotic valve that you can see on our right here, whether it be either due to congenital reasons having that narrowing of the valve, or it could be due to that becoming, instead of tricuspid, is bicuspid. The thing to want to touch more upon here is kind of knowing your murmurs. So this is your right upper sternal border, systolic ejection murmur. And this is a little different from hokum, where you have If you go from squatting to standing, you have that decreased venous return. It actually decreases instead of increase, and this has to do with less flow going through that valve, so less of that murmur happening. And the main takeaway here is all about that narrowing of the aortic valve, or specifically more about that pressure gradient to kind of help you with the return to play. Kind of highlighted here, if you're asymptomatic and mild, you're okay to participate, and you just need annual evaluations. If you're asymptomatic and moderate, then you kind of can only do moderate static and low and moderate dynamic sports. So pick kind of these four quadrants here. If you're symptomatic in any way, it doesn't matter what your pressure gradient is, or if you're severe gradient, then you cannot participate in competitive sports. And these are the pressure gradients. I doubt that they would test you on the numbers, so most likely they'll tell you mild, moderate, and severe. Another one here will be mitral valve prolapse. Just know that if they say anything along the lines of mid-systolic click, kind of should prompt you to think about mitral valve prolapse. The major thing here is obviously be able to diagnose it based on echocardiogram with that prolapsed mitral valve, as you can kind of see here, where you kind of have that ballooning and then you have a low leakage there. And the other thing is you want to do a Holter monitor to look for any arrhythmias. All right. Here's one of our didactic sessions, hands-on didactic session. Shout out to Dr. Solomon for teaching me and Kevin some of the basic omen. That killing was probably just like, this is boring, and he's just there as another teacher at that point. So question here, which of the following statements regarding participation in competitive sports is most accurate in patients with aortic stenosis? Any takers?
I was going to go with the D, with D for dog, but I'm
D?
between D and E, the last two options.
Okay.
I think the longer it takes me to read an answer stem usually means it's probably that one.
So which one are you choosing?
I think I've had this one before and I always forget and I always have to re-memorize it, but I think it's B because you need to
Yeah,
do all of
yeah,
the things.
yeah. So main thing here, kind of going from top to bottom from A. So A, you need annual evaluation, so you can't just do just initial testing. C, when they say severe, it just says, hey, you can't compete. So remember, severe is you can't compete. If they're symptomatic in any way, they can't compete. And E is a little bit kind of trick question, but they can do low intensity recreational walking. They just can't compete. And B, I wanted to kind of get you kind of think about in terms of moderate aortic stenosis means moderate static and dynamic exercises. So kind of just out moderate equals moderate is how I thought of it. This one's a little tougher, but I thought that was important to kind of go through. This part right here, 22-year-old male baseball player coming for pre-participation. He has that late systolic murmur after a mid-systolic click. Denies history of sudden cardiac death in the family and denies any cardiopulmonary symptoms. He had echocardiogram 6 months ago and no significant regurg. Ejection fraction is normal. What is your next step?
Probably D, get the Holter.
Yeah, exactly. I try to kind of emphasize that when I was kind of going through the mitral valve prolapse, and yeah, you want to make sure you get that whole Holter and as well as that echo, and using both of those information to help you guide next steps there. And I quickly glanced through it, but there are 6 criteria. You can kind of go back and take a look. They all have to relate to basically either symptoms or what's on your echocardiogram or and what's on your Holter to basically determine if they can be cleared to play. Awesome. And here's us in one of our journal clubs, and this was also our send off to Dr. Flannery as he went to Houston there. All right, we're almost there, guys. So primary electrical diseases is another cause of sudden cardiac death. The 3 of them I will highlight that are quick is long QT, Brugada syndrome, and Wolff-Parkinson-White or WPW. There's a long QT syndrome. The reason they love to test this one is it's the most common ion channel disorder and prolongation of that QTC. And they love to talk about swimming as the subtype of a long QT syndrome. Subtype number 1 can trigger ventricular arrhythmias. And here's a kind of talking about prolonged QT. So we all know that less than 440 and less than 460, whether it be male than females, then that is kind of the cutoff. And you can see kind of the quick and dirty way of looking at this is kind of if you have a normal QT that is less than half the preceding R to R interval. So if this height of this T is more than halfway of this R to R, then they kind of are suspecting kind of that prolonged QT. This one's obviously really obvious there, but some may not be as obvious as this one. And as I kind of alluded to, like swimming is just not recommended if you know that this long QT syndrome is subtype 1. Otherwise, you need to place a AICD or a defibrillator for those that are high risk, and you can consider return to sport after 3 months if you have no shock from the ICD. Next one up is Brugada syndrome. This one is a little bit unique in that it can cause ventricular fibrillation and sudden death during rest or sleep, which is different from everything else. And you see that EKG finding of that high takeoff, as you can see on the left here, and then having that downsloping ST. And this is to contrast it with that normal one, where you can just see that you have that early repole there, that ST elevation with that early repole. So different morphology that you can see there. This is what you would see on a 12-lead EKG. Again, same thing, that high takeoff and then having that downsloping ST wave or ST segment. Things to know here is obviously if they're asymptomatic, they can play. But if they are symptomatic, if you optimize it and you give them a pacemaker, a placement of that defibrillator, you can think about playing if there's asymptomatic for 3 months. Next one up is our favorite. I think this is one of the things that they love to test about is kind of that WPW, having that accessory pathway that conducts electrical signals that's quicker and different from your usual conduction from the atrium to the ventricles. In this one, their EKG findings that they will test on will be that delta wave or having that upstroke in that QRS, which I'll kind of show next. So you can see here having that upstroke, having that here at that QRS complex here on that V5, V6. Return to play here is if you're young or if you're and symptomatic, they will then go ahead and do electrophysiology study and ablate that aberrant pathway. But I noticed that also they said that if you're greater than 25 years old without symptoms, you can consider just to go ahead and play without intervention. And I was kind of confused as like, wait, why are we doing this? So the main point is that if you're over the age of 25, the likely and you had no symptoms prior to this, or few symptoms prior to this, the likelihood of that aberrant pathway becoming like more active than it is less so. And so it disappears over time, and due to the kind of that natural remodeling of your heart tissue, that aberrant pathway gets less and less used. Here's our luckily we get to work with Dr. Boswell with our Cleveland hockey, our minor league hockey team here. I did not get a picture, so I found a picture of Cody and Dr. Boswell, which is awesome. On the right side, that's just my picture of how at one of the games. All right. Question here, you're seeing a 16-year-old female athlete for pre-participation physical. had a syncopal event during an exercise, thought it was dehydration, didn't seek evaluation. Mother or father may have a heart problem, but don't know any of the details. EKG showed this QT interval. They went to cardiology referral, had that long QT syndrome type 1 genotype that they found, which sport listed below would be a high risk of sudden cardiac death.
Swing.
Awesome. I feel like I've kind of belabored that one a little bit more. Next question here, which of the following statements is true about Brugada syndrome?
The high takeoff, down sloping ST.
Awesome. Yeah, exactly. This again is just me belaboring it, and you can know that, B, slur upstroke, that's the delta wave, which is not along with the Brugada. So that's just something to kind of note and distinguish between that. Last question of this set, 19-year-old male college lacrosse player, race heart was racing intermittently, resolves in a few minutes, denies any symptoms, and he's healthy, has no family history of cardiac disease or unexplained sudden cardiac death. And here's the EKG that you get. Anything that stands out for you guys?
Yes, the WPW notch in the beginning.
Yeah, so you can see that V5 and V6, the delta wave there. So based on your EKG findings, what test would you order?
Electrophysiology.
Yeah, awesome. Yeah, electrophysiology, and then can see right there, as I pointed on in that arrow. And then this is to a spring season. I kind of got a little tired, I guess, with taking pictures at this point, but here's me and Sabrina at Lake Erie College Cross that we were covering. Last little home stretch here, acquired heart diseases that can cause sudden cardiac death. Here are the three. The one that really we'll talk a little bit more about is commotio cordis, which we have heard a lot more, especially with recent athletic events. So this is a blunt force trauma at a blunt trauma at specific timing, unfortunate timing at that prior to peak T wave here, as you can see here with that ventricular reposition. Most of the time it's due to a projectile such as baseball. Sometimes it can be like football where they tackle that right specific that time. And you can cause somebody to have collapse instantly or a couple seconds after because their rhythm becomes ventricular fibrillation, unfortunately. And this is something that you got to recognize and you got to defibrillate quick. Something to touch a little bit upon is atherosclerotic coronary artery disease, which we know about. The reason this will be testable is its most common cause of sudden cardiac death in athletes over this age of 35. They love to test about if you have these risk factors, it's highlighted here, hypertension, dyslipidemia, diabetes, and this person talk about, hey, I want to start a new exercise. You want to do some screening, as you can see there from 1 through 4. And also, if you are someone who has this risk factor and want to do competitive athletics, you want to go ahead and screen them, as you can see there with all the various different testings. I'm not going to go over these ones. This is kind of just background information. You can review a little bit more about atherosclerotic diseases and kind of the acute coronary syndrome that comes with it. And next one up is myocarditis. So it's inflammation of the myocardium most likely due to viral illnesses, and can cause symptoms of heart failure, unfortunately. So you would have these physical findings of edema and crackles at base of the lungs, and you can see an echocardiogram having that reduced ejection fraction. The main thing I want to highlight on this one is that you do not want to give NSAIDs, as that can increase mortality and increase your risk of heart failure with myocarditis. And then it's all about that inflammation and scarring that can cause electrical instability. So you want to avoid that in sports for 3 to 6 months. And then they would then follow return to play under the guidance of a cardiologist. Last one here along the lines of sudden cardiac death with atrial fibrillation. This one's at least what I saw when I was kind of taking all these practice tests. There wasn't as many things talked about there. but you guys know this is a regular rhythm. And the main thing I want to talk about here is really because of regular rhythm, they will need anticoagulation unless they are able to get it back to sinus. And with various different pharmacologic or interventions, the main thing here is that if they are on anticoagulation, they cannot be on contact or collision sports. This is just me with my parents at our this year's annual meeting at Kansas City. This is our fourth year doing this together, and I'm looking forward to doing that in Seattle next year. Question here, which of the following is true regarding commotio cordis?
B.
Yep, awesome. So like we talk about, it's that unfortunate timing of getting hit right before that that kind of peak of T wave there. And here's us at the conference with our posters, all four of us with Dr. Cup. And then here is me with Dr. Flannery. Got to catch up with him a little bit at Kansas City. Last topic here is about hypertension. This I thought is a really important topic, whether for you kind of more clinically and also for the test. So knowing the numbers, we're here having normal, elevated, stage 1 or stage 2, whether it be adults or adolescents. And something to note here is for adolescents, they adjust the percentiles based on age, sex, and height, and that was something that was tested. And thing to note would be kind of the secondary hypertension, where if they kind of talk about, hey, like what's causing their blood pressure, so you got to kind of rule out all the secondary before you can say it's the primary hypertension. So things they might talk about would be kind of NSAIDs, oral contraceptives, and supplement use like caffeine, among other things as I listed there. But these three are kind of the more standouts. How to diagnose hypertension, it's elevated blood pressure in two separate occasions. And the things that you want to get for evaluation is listed there for basically end organ damage for CDC, BNP, lipids, TSH, urine analysis, and EKG. And the main point here is about kind of that participation in sports with relating to hypertension or elevated blood pressure. So if you're elevated, you just encourage lifestyle. So elevated meaning like systolic of 120 to 129 and then less than 80 for diastolic. But if you're stage 1, meaning 130 to 139 and greater than 80 but less than 90 diastolic, you kind of then will need to do labs and see if they have any end organ damage. If it's none, then you kind of recheck in blood pressure 2 to 4 months. If there is, then you have to limit them, and they can choose either lifestyle or pharmacologic therapy to control their blood pressure, and then you need these end organ changes to resolve. And then stage 2 is anything above 140 over 90. And this doesn't matter if they have end organ damage or not. You need to limit them and start your blood pressure medications. And then they can safely resume once they are controlling that blood pressure regimen. Or if you do have end organ damage, that need to also be resolved. Last topic here will be kind of treatment of hypertension. Kind of you have your non-pharmacologic here slide about kind of decreasing sodium, fruits, vegetable, low fat diet, weight reduction, regular exercise. But main part here that they will test on is more the pharmacologic, which one you want to choose and for what reason. So first one about ACE and ARBs. This is the first line because it doesn't have any impact on your cardiac function. But something to also note is that this can cause dry cough, especially with the ACE, especially like Cinepro. And then something to also consider is that it's contraindicated in pregnancy. So female athletes that are capable of being pregnant, you might not choose this as your first go-to. The other medication you might use would be the dihydropyridine calcium channel blocker because it doesn't affect heart rate. I would not do the dihydropyridines given that has AV node suppression. Something to also note that it can cause some lower extremity edema, which can maybe throw off their gait or their running pattern. Thiazide is basically just they're going to test you because it's a banned substance because it can dilute urine and mask their ergogenic aids. And also it can cause dehydration because thiazides, as you guys know, you can just basically be peeing a lot. And last one here, this is beta blockers. It's not a, right now, it's not even a first line for blood pressure, but they still have it in the book here. But you usually use the non-selective, cardioselective beta blocker, but this can help performance anxiety, but in precision sports, it's banned. But also the other part is it's not really great for athletes given that it can decrease VO2 max, maximum heart rate, and endurance. So really not a great option. So really out of all this is kind of thinking about using your ACE and ARBs and on your dihydrogen calcium channel blockers like amlodipine. All right, you guys made it to the end. Here's our most recent event at the Cleveland Marathon. We had an awesome time there. Awesome. Last couple questions. You have an 18-year-old pre-participation examination, no prior medical history, does not take any supplements. You notice some elevated blood pressure readings. EKG and echocardiograms are normal. You repeat the blood pressure in a few days and it's still high. So you decided to do some fasting labs. So which of the following combinations of blood pressure readings and laboratory findings would restrict you from participating in physical activity?
Last one, option D, because
Yeah.
it's second stage.
Yep, perfect. Yeah, exactly. This one, it's more about that blood pressure. If you're above 140 over 90, you can't, you want to keep them out from participation in competitive athletics. Awesome. Last question here. You're a team physician for D1 at college. You have been carrying a female track sprinter. You've seen her weekly in the last 3 weeks and you notice blood pressure readings to be high in that stage 2 range. Thorough workup you've done, no secondary causes, no end organ damage. In addition to a lifestyle that failed to this point, what medication would you want to start? She has no known allergies.
This is ACE and ARB first, right? So
Mm-hmm.
D.
D, gotcha.
I wanted to say because she's a female and she's probably reproductive age.
Oh, that's
We
right. Shouldn't put her on that.
we go for amlodipine.
Yeah. Or hydrochlorothiazide. Make her run really slow and put her on a beta blocker.
What's your final answer, guys?
Amlodipine.
Yeah, gotcha. Yeah. I made this question harder than it was because I wanted to kind of incorporate all the things that we kind of talked about. So it's a female, so that makes a difference why lisinopril is not the choice. Diltiazem, that's a non-hydroxypyridine calcium channel blocker, which can cause decrease in heart rate. So you probably don't want to do that for a track sprinter. Same thing, same idea with the beta blocker from metoprolol. You don't want to do the hydrochlorothiazide because it's a thiazide, so it dilutes their urine. So D1 athletes get regular testing, so you don't want to do that. So the option that you do have would be amlodipine. And the take-home point, hopefully, after going through this, this diagram becomes a little bit more easier to digest. At least for me, it did, just to be able to go over that with some context to this diagram. And also, obviously, knowing your blood pressure, knowing what's normal, what's elevated, what's stage 1 and stage 2, and why you want to choose which certain antihypertensive. Really, it just comes down to ACE or ARBs or amlodipine is more or less kind of your choices. Thank you, everybody. This is our at the annual meeting, kind of meeting some of their former fellows, and which is awesome to kind of get to talk to them about from them. Questions, comments?
Mandy, if you're on, do you want to comment at all about what your questions were when you researched it? If you remember.
I've already told everyone.
Yeah.
They all know. Like, you just have to memorize all the pictures in that article of the EKGs. Like, those will be the questions. They use the same pictures that are in the article on the test, and
Yeah.
I assume it's because they've already gotten permission to use them, so it's cheaper.
Yeah.
But it all
Yeah.
came from that. Like, and
Yeah.
then the correct blood pressure medicine, depending on, like, there will likely be a blood pressure question and which medicine to choose. Like, someone may have a chronic cough, so you're not going to use the ACE in that person, right? Like, they'll
Yep.
come up with some reason why you want to pick one versus the other. And I've given up on trying to understand the cholesterol medicines personally. And I don't know, just pick statin every time and figure it's right for at least one of them.
Yeah.
But I'm a pediatrician, and this is just, good luck. There's probably going to be one cholesterol question, and all of you people who study adult medicine will know it, and you'll be like, why would anyone get this wrong? And my answer is because I'm a pediatrician and I don't know.
And
But
my EKGs that I show here are from that article. If
yeah,
yeah.
And just like knowing the juvenile patterns and the patterns for Black athletes, there's generally, I had a question on, I don't remember whether it was the juvenile or the Black athlete, but they really like knowing when the T waves are normal and abnormal. They like that one a lot. But again, if you just memorize all of the pictures, you will get that right, because that's one of the ones in there.
Jack, I thought your talk was really focused on like hardcore CAQ,
Yeah.
cardiology stuff for sure. Like I tried to pound this out of my studying early so I can frequently revisit it because it's not my strong suit.
Yeah.
So, it was nice to kind of have a little refresher as we get closer to testing.
Yeah, I felt this kind of working this way was really helpful to me to, like I said, to put some context into that this diagram here, because it's just a lot of bullets that doesn't really help me. So I thought having a little context to it and kind of be able to make it in a simple, digestible manner, just knowing that you need to know like all these four things means abnormal, and then there's not, and everything else is kind of recognition.
And I took the article from Mandy and I cut it into tiny pieces and just made flashcards out of all of the
Yes, which is exactly what I did. Is I put the EKG on one side and the interpretation / determination on the other. And then Jack, the other thing that Jack did that's really important to remember is that symptoms matter a lot. Like, all of these asymptomatic people, for the most part, we're not going to do a whole lot with them, right? Like, unless they have, underlying long QT or something and 4 family members died, that's different, but symptoms matter.
Yeah, I guess I should preface. I meant symptoms does matter, but in the sense it doesn't unfortunately distinguish between all the different pathologies.
Oh yeah, no, I mean if they have symptoms versus they don't have symptoms. So the completely asymptomatic people, for the most part, we're not worried about, right?
Yep, exactly.
So, but Jack is also correct in that they all kind of have the same symptoms.
Yeah. And then I'll put this into more clinical context, which is a week from today, we're doing mass physicals. So, your talk kind of gets at one, asking about symptoms, which can be a red flag, but more importantly is really asking about family history. And a lot of times we have kids come through mass physicals on their own.
Yeah.
So, I almost always ask them, did like your parent fill out the form or did you fill it out with them? And if they just filled it out on their own, or if there's something marked that's concerning, I honestly make almost every kid just call their parent and talk to them directly to clarify family history. And then I think probably my most classic story from our mass physicals was, I think, literally like the third person through a couple years ago. The mom walked him through and they had maternal aunt who had died from ARVC or ARVD, depending what you'd like to call it. And mom was known to have ARVD, and she walked the kid through, and the kid had never seen a cardiologist.
Oh,
And I was like, well, I can't clear you until your kid's been evaluated by cardiology. And the mom's like, but she doesn't have it. I have it. I'm like, okay. And your sister died from it. It's genetic. Like your kid has to get checked, right?
yeah.
So I held the kid out, and she was literally like the third person through. Mandy, were you with me that night, or had you left? It was like your anniversary night, and you guys are going out to dinner. And this mom literally walked down to the lobby and started like blast social media messages saying like how awful we were, and that, you know, kids shouldn't go through and get their physicals, and was like telling people not to have their kid get their physicals with us, to the point where Voos was like coming upstairs asking what the hell I had said to the poor family. And it just kind of underlines that no matter how much hubbub you create with holding somebody out, like you really have to take this stuff seriously and make sure kids are getting checked. You know, and that family history is going to be the number one thing you find that's concerning more than anything. And I mean, I see people come through just regular clinic and they report, oh, yeah, father deceased. And then you ask why, and you find out dad had a heart attack at 42 and died within the last 6 months. And the kid's in just for a knee checkup, but they haven't seen anybody. So, you know, like that family history and capturing an appropriate and accurate family history is probably the most important thing to do when you're doing mass physicals, because we all know your odds of finding anything on exam or hearing anything about symptoms is just really low.
Yeah. My favorite story for the family history one is Susan and I had separately saw twins at Case who had wildly different family histories documented. We then called the mom, who's like, yeah, they're both wrong. So even college students have no freaking clue what their family history is. And sometimes when you have a parent in the room, they don't know either, because, you know, the boomers and older never really talked about this stuff, and they hid all of this crap. And then they call and they're like, oh, as it turns out, you know, we have all of these things in our family history, because, you know, sometimes when we see them in clinic and we have time to deal with it and they actually come back and see us again, the families are then able to call both sides and they're like, well, we got a lot more information, and let me tell you about all this stuff. And they're like, I'm glad you asked, because now we all know. But explaining genetics to anyone is very difficult. Even when I went to get my echo, the tech is like, why are you here? And I'm like, because my son has this heart defect. And she's like, okay, but why are you here? And I'm like, because my son has a genetic heart defect and I need to see if I have it. And she was like, I was like, you know what, can you just do it? I'll pay for it. It'll be fine. Like, don't worry about it. Like, let's all just get on the same page and do it. Like, so explaining it to medical people is difficult. And I was there, Susan. We were both like, that's fine. You don't have to, we're fine if you leave and take people with you. Like, we would all like to go home.
Yeah. And I mean, the family history component is so hard with mass physicals. And, you know, I'll make sure that who's running them? Josh? I can't remember.
Yes, poor Josh
Like,
is now doing it.
Like, I think I'll just remind him, like, they should send the kid through with the parent every time. Like, I'm a firm believer the parent should be with them through physicals. And the main reason is the family history, but then also it gives you an automatic, you know, person in the room when you're examining them. So there's no issues. So I'll remind Josh, like they, you know, like if there's, you know, send the parent through with the kid. It's just so much easier for us than trying to get them on the phone. And like Mandy said, sometimes the parent doesn't know because it's on the other side of the family, and a phone call needs to be made, but you just have to take the time and do the phone call.
And remember, the parents that are pitching a fit because you refuse to clear their kids are also the first ones to sue you for lots of money if their kid is injured or dies. So, because that's the personality.
Very true. All right, everybody. And on that note, happy Friday.
Yay.
Happy Friday.
Happy Friday.
Suze, call me and we'll look at that x-ray.
That's fine. All right, you
All right.
guys have a great weekend.
You too.
Bye.
Great
Thanks,
job,
Jack.
Jack.
That was awesome. See
Thanks,
you guys.
Jack.
Good job, Jack.
Thanks. Have a good one.
Bye.
Thank you. Bye.
Yep, no problem.